For potential fracture, what you can perform is a tuning fork test. You can take this kind of a tuning fork with proper weights on the tip. What you're going to do is you're going to create the vibration by hitting this tuning fork maybe up against like a bottom of your shoe, and you're going to place this end of the vibrating tuning fork on the bone that you're suspecting the fracture. We typically start with the healthy side so patient can tell what the regular vibration should feel like. It should not be painful at all. And if, for example, I'm suspecting the fracture over the distal fibula, maybe here in the tip, I can even start with the fibular head, medial away from the pain, to see if that is going to be strong enough to cause any vibration along with the bone to cause any pain here. Or I can start with the tip of the toes, and that is going to transmit some vibration over here at the fracture site. Positive test is indicated by the pain, but we're not here talking about soreness. We're actually talking about significant pain, that they might jump off the table and then start to go like, "What did you do to me? It really hurt." Kind of a pain is what we're looking for. You can also perform percussion tests, also known as bump test, tap test. There are a couple different versions of this test in terms of the name, but what we're trying to create is very similar with the tuning fork. You can try to create the vibration on the bone using your own finger. For example, if I'm suspecting a fracture along with the like a lower leg, what I can do is I can try to use my hand, use the heel of the hand to hit the heel a couple of times to create the vibration up again, along with the tibia and fibula. If I'm suspecting the fracture in the toes, like there was one of the phalanges or metatarsals, what I can do is I can try to flick the tip of the toe, again, to create the vibration across the bone. What we're looking for is the pain, and it's typically, again, the severe kind of a pain instead of, I can kind of feel a little bit of a soreness kind of a pain. Another test you can use when you suspect a fracture within the long bone, and when I say long bone, I'm mainly talking about metatarsals here in the foot. If you had to say suspect a fracture in the hand over the metacarpals, you can also perform this test too. But what you're going to do is pretty simple. You're going to grab one end, using one hand, and then the other end using the other hand. You're going to apply some axial loading of the metatarsal. You're going to compress that bone. Okay. If they don't have much of a pain, you can even add some twisting force. We're going to be looking for pain. Also, if say fracture is happening right in the middle, by applying a compression, you might also be able to kind of create the false joint in the middle, some kind of false motion that you're not really supposed to be seeing unless the patient having the fracture. And the next injury we have is a disc flank injury. So you can sustain a sprain of this joint or dislocation or fracture. I think we kind of mentioned a little bit earlier. The classic mechanism is looking like this. So you're landing on extended toes, and again, I think we mentioned this a little earlier. It looks very familiar. Depending on what type of the injury that you sustain here, if it's a dislocation, you might see nice deformity. If it's a fracture, you also might see some deformity. This is a nice X-ray of the dislocation. Some other dislocations too, moving a little bit different ways. If it's a sprain, you might actually find the midfoot instability, which you can actually confirm that by performing a joint play, between the tarsal bones. People would also maybe start to exhibit some ecchymosis over the pon aspect of the foot. Intermetatarsal neuroma. Neuroma means some kind of the growth of the cell, around the nerve tissue. It could be just a benign tumor, just a mast cell growth, really for no reason. Nothing is cancerous. But the problem is when you start to kind of grow some new tissues around the nerve cells, that can easily put some pressure over the nerve. Here's a good picture of the neuroma, and here's the actual tissue, of the neuroma. So around this nerve tissue, you start to, build some cell formation. So nerve is going to get trapped in between metatarsal heads. You used to have a very narrow space to begin with, and now you got a little extra chunk of the tissue. Pain would often occur upon the surface of the foot, and it might also create some numbness, tingling, burning sensation. If you are to deeply palpate this area, you might actually be able to feel this nodule formation. If you have to play with this joint, intermetatarsal joint play, you won't find the laxity because I'm not talking about ligaments or joint capsule being stretched or anything at all, but they might complain some pain because of this tissue irritation coming from the neuroma. If you had to perform the squeeze test, that would probably come back positive. And this neuroma, if you happen to have this between the third and fourth metatarsal head, like you see in this picture, we have a very special name for it. It's known as Morton's neuroma. And here's what the squeeze test will look like. It's very simple. You're going to use the hand, grab the patient's foot, okay, around the metatarsal head. You're going to squeeze it together. And depending on what you read, some of the book might say you need to hold that squeeze for like a minute or two. Okay, so what we are again looking for is a recreation of the sign and symptoms. So it could be burning, could be tingling, could be pain. Okay, so if it's more of a neurological sign of symptoms like numbness, burning, tingling, that could indicate a neuroma like we just talked about. If they happen to complain the pain along with the metatarsals, it could actually indicate a fracture too. So we can actually use this test for two different purposes, but we're looking for two different things. Okay, it's also known as a Muddler's sign or Morton's test. There's only one study that examined the efficacy of this test. Sensitivity seems to be very decent, 88 is good. Quantity is somewhat low, and we don't really know anything about other values, so if this is the only test that we can use to confirm the neuroma, I would say go ahead and use it, but just interpret it very carefully. Some other conditions that can affect the big toe: halcus limitus and rigidus. Limitus is where you start to have a little bit of some bone formation as well as the cartilage degeneration. Here's a nice healthy MTP joint of the first toe. It can slide on each other, you can move it nice, but here's the limitus. Okay, you start to lose some cartilage over these two articular surfaces, and this is going to be nice bone-to-bone contact. So it's going to be a little bit difficult for you to slide. You're going to start to experience some limitation of the range of motion. If it starts to get really bad enough that you are now experiencing excessive exostosis, bone spur formation, that could almost physically limit the range of motion. You're probably going to get the nice bony heart and feel. Okay, that is rigidus. So that's super rigid that you can't even move it much anymore. So they're going to have pain over the first first MTP joint. You're going to have hypomobility or significant limitation of the range of motion. Some bad cases, you can actually see the bone formation sticking out nice and big. This is kind of a little bit more of mine. You can see the information. It's nice and red, a little bit big, but these are really bad. If you have to get an x-ray, you might actually be able to visualize the bone accumulation in the same spot. Halcus valgus, we kind of mentioned that deformity already. So if you happen to have this nice valgus angle right at the first MTP joint, and then it's officially bigger than 20 degrees when you get an x-ray, you can officially call that as halcus valgus deformity. Okay, this is a progressive condition that it might start out pretty mild, but gradually start to get worse. Again, what you would often experience with it is a subluxation of the first MTP joint. Okay, this phalanx is supposed to be facing this way, gradually start to move, and then now subluxed. Okay, it could be caused by, or could potentially get worse by, wearing the improperly fitted shoes or some friction coming from the shoes, pes planus. And this particular deformity is going to lead to a very specific injury, because here, we're just talking about the deformity. It's not an injury, but it could lead to a very specific injury known as bunion. Okay, so here's the official definition of the bunion. You have to have a combination of halcus valgus, which is bigger than 20 degrees of valgus deformity at the first MTP. You also would have to have these other conditions. You have to have some exostosis accumulated over the head of the first metatarsal, so some bone spur. You also have to have a bursitis. You have this small bursa located right up against the head of the first metatarsal, but you have to have information there. Plus, the last one is the callus formation. Okay, excessive thickening of the skin, even again try to protect the body part, but also kind of making the condition worse. Okay, it's going to take some time for anyone to build up this condition, so the bunion condition is almost always a chronic condition. If you're to develop exact same condition but over to the other side, the pinky toe side, okay, we don't call that as a bunion, we actually call that as a bunionette, but very exact same thing happening over to the other side. This condition is also known as Taylor's bunion. Some extreme bunions, it might lead to some overlapping toes, as you can see in some of the pictures. If it's very extreme, like pictures that we're looking at right now, those individuals might need to have a surgery. Okay, if it's mild, we can try to reduce it by maybe trying some taping or trying to insert something in between the toes. But if it's bad enough, surgery might be the only option. Picture that we're looking at here on the right, this is a picture, the kind of before surgery picture. This is the after surgery picture. The outcome of the surgery is typically very, very good. Turf toe. This is a sprain of the first MTP joint, typically caused by hyperextension. Okay, so maybe you just landed awkwardly on your toes and ended up hyperextending your first MTP and then sprain the joint capsule or the ligament that you have on the bottom. That is known as turf toe. The other potential mechanism is actually hyperflexion. This is a possibility too. So maybe when you're running and then try to suddenly stop yourself, and then your foot often keeps sliding within a shoes, and then your finger end up getting jammed in front of the shoes, and then maybe you experience a significant hyperflexion of the big toe. You can sprain the opposite side. Okay, so you can maybe sprain the top portion of the joint capsule or the ligaments that's sitting on the top. We still call that as turf toe, just a little bit different mechanism. We can potentially try to tape up this injury using the very specific strong tape known as moleskin. Try to pull the toe down a little bit. If it's a hyperextension injury, we're going to pull the toe down because they're typically good at the flexion down and want to keep it in the flexed position. So we can try to help them out. But turf toe typically is a very painful injury because no matter what you do, whether you're running or jumping or cutting, changing direction, you're going to use your big toe a lot to push off. So this may not be super horrible injury structure wise, but functionally it's a very painful injury. It's very disabling. Some other conditions, the interesting one for you to know is osteogonum syndrome. This is actually the condition where you actually have an extra bone in the foot, accessory bone. This bone is often found between the talus and calcaneus. You see this nice osteogonum, little extra bone sitting in there. Now, some people may have it and then may don't even realize that they have this condition if they're not really causing any issues. But think about this: if I'm a dancer or cheerleader or something, and then I'm gonna be on my toes a lot, I do a lot of plantar flexion repeatedly. There's a chance that maybe I'll create some pinching over this bone, soft tissue, and then maybe this bone will get pinched, so to have some information. Or if it's bad enough, I might actually fracture this osteogonum itself. Okay, so it's rare. It's not very common, but it's a potential possibility for you to think about. Some other conditions, you can actually have some fusion of some tarsal bones. Okay, so for example, what we're looking at here is a calcaneus and navicular connecting together as one bone. Okay, so this condition is actually calcaneal navicular tarsal coalition, where you start to see some fusion of the tarsal bones. Okay, some of the bad cases, you might have more than, say, two bones connecting together. Some of the cases you might have to have surgery to physically separate those bones. Some other conditions that you don't really have to know, but it's nice to know, and you might come across with these cases in the future. It's definitely possible for you to sustain fracture over to your tarsal bone, say talus, calcaneus, navicular. Heel contusion is also a good possibility. We did talk a little bit about the fat pad. Okay, so if you had to contude your calcaneus or the fat pad that's located right underneath, that's typically a very painful condition. This x-ray actually is indicating the cuboid being subluxed. This is a normal regular cuboid, but this cuboid looks like it's got shifted a little bit too far. So cuboid subluxation. Retrocalcaneal bursitis, this is a small bursa that you have right deeper, a little bit deeper to the Achilles tendon. So you could potentially develop this bursitis as a chronic injury. And Sever's disease is a bony spur, okay? Coming from the constant pull from the Achilles tendon. It's most commonly seen in a younger population where they're actively growing and the calf muscle, just having a very hard time catching up. So just to review, these are the conditions and special tests that you're responsible for knowing. If you have any questions, feel free to ask me maybe either via email, or you can ask me in class when we meet again on Tuesday.